Welcome. This is Jason Clemmons, Doctor of Chiropractic at the Rock Health and Wellness Center, and this is Life with Jason Clemmons, DC. It is Monday, April 22nd, and we are live right here from the Rock Health and Wellness Center studio in Lubbock, Texas, and all over the world in Facebook land, YouTube land, and Twitter land, and on the radio live right here in Lubbock on 98.7 Walk by Faith and 1420 AM Lubbock Christian Nation. So, it's Monday. We're back at it again. We had an interesting weekend here. Guys that saw last Friday's show, you kind of understand what went on in my life. And my dad did pass away on Saturday, and that chapter is over. And so we're moving along, and everybody's fine. The family's good, and we're good, and I'm good, and we got that got that all done and finished. So I know my dad's just out of pain, so he got got himself through that. But I just want to say thank you to all the people who reached out, all the sweet texts that I got, the kind words that I got spoken to me today about that. I really appreciate all that, and it's just part of the deal. It's just part of going through it. It's just part of life. It's just, and that's why I was so I just felt so convicted last Friday to just talk about it, and because it's it's just something that we all deal with. Um, we're not unique compared to anybody else, and um, but you just have to. It's part of the game, right? And not all of the game is always just fabulous, and that's not true. It is always fabulous if you understand the definition of how to define fabulous. But there's balance in the universe, and God didn't disappear. That's the one thing I know. And it's just kind of like some days is some moments, half your moment, half of every moment is fabulous. Another half of the moment's not so fabulous, and so you just got to learn to balance those things. And this was a major component of. I mean, this is a big deal, right? It's like you lose your dad. That's a big deal. And it's like, look, it's the way it goes. It's life, and I'm okay. And I'm good. It was just sad to talk about on Friday, but I'm good. My mom's good. My brother's good. My sister's good. We're fine. The kids are all right. Everybody's good. Part of the deal. We're moving on, and I know more than anything else, it's so peaceful to know that a man who was suffering as much as he was suffering is finally done with it. So thank you very much to all of you out there that said kind things to us and sent us texts and supported us. I really do appreciate that. My family appreciates that, and thanks for spending part of your life with us. And I'm glad we could do that. So um, just like uh, Dad would want, and it's gonna it's gonna free me up just a little bit because I've held back some opinions and some thoughts and some. Uh, the way I feel about some things to try to be very respectful of, and to a certain extent, to be respectful of what Dad was going through. But um, not only is he free of that body, but I'm now free of that body, and it's uh, it's going to free me up a little bit to talk about some things that I couldn't necessarily talk about while he was going through them. And a couple of them are the articles that I have for us tonight. So we're going to talk about diet drinks. I got the request actually um, from one of the girls that I know that said, "Hey, did you talk about diet drinks? Because I talk about um, I talk about them with my friends, and they don't believe that they're bad for you." And so would you talk about that? So that's going to be the topic of tonight. We're not going to take health to church tonight. I didn't get to church yesterday. We had family in town, and it was kind of a busy day, and so we dealing with the things that we dealt with this weekend. And so we're maybe if I get a chance to get that sermon broken down, we might bring health to church later on this week sometime. They've been some really good series that have been going on. So I really am looking forward to them. I just haven't. I just didn't get there yesterday, and so we missed that. So that's not what we're going to talk about. We're just going to pick up with that with what we talked about last week. So um, I got my my article service that I get from Dr. Dan Murphy, it keeps me educated on a lot of stuff globally. Dr. Murphy's been doing that since 2009, and um, so he got some new articles that he just hot off the press. And there's a couple of them, and I thought it would be nice to just start off with them right here tonight, and we can talk about them. And these are like pretty they're pretty cool, and they're the same things that we talk about. But a lot of the times I cite these studies that are a little older, and so I just thought it's like, hey, here's the same subject, but it's in a different journal, and it's brand new, and it's talking about the effects of omega-3 polyunsaturated fatty acid supplementation for patients with osteoarthritis. So you guys out there that have osteoarthritis, this comes from the Journal of Orthopedic Surgery and Research, May 24th, 2023, volume 18, number one, article 381. And it's several, these look like Chinese names. I'm not going to try to pronounce them, but the study cites 35 references. These authors performed a systematic review of meta-analysis to comprehensively evaluate the influence of omega-3 fatty acids on symptoms and joint function of patients with osteoarthritis. A lot of times patients want to tell me, that's what my dad from was or dealt with his whole life, ankylosing spondylitis, the spinal arthritis. Well, it's like, what I got this thing that's going on in my thumbs, or my hands have a problem, or my joints have a problem. I got this global arthritis thing that's happening, and you may have osteoarthritis. This is 9 randomized clinical trials (RCTs) with 2,070 patients with osteoarthritis contributed to the meta-analysis. The follow-up duration were 1 to 63 months, so they followed them up for 5 years. And it just makes a point that worldwide osteoarthritis is the most common degenerative joint disease affecting cartilage and surrounding tissue, which has become a leading cause of disability worldwide, particularly in older populations. With a growing elderly and obese population, the incidence of osteoarthritis in recent decades has been increasing. This has also resulted in substantial economic burden for the global population. It just kind of strikes me right now as I hear that. 'Cause I hear that a lot. I hear that a lot, and I don't think anybody cares about that at all. I don't think that is a factor in any. Um, I could be wrong, so I have to be careful. But it just hit me while I was looking at that. The incidence of osteoarthritis in recent decades has been increasing, and this has also resulted in a substantial economic burden for the global population. It's You would think if it was a substantial economic burden for the global population that we would address it instead of just feeding drugs to it, right? I'm gonna get into that in just a second. Uh, due to the adverse events associated with long-term use of osteoarthritis drugs, patients have been seeking alternative and complementary agents for relieving the symptoms and improving the function of the affected arthritis. Omega-3 fatty acids confers anti-inflammatory efficacy. Omega-3 fatty acids, mainly including EPA and DHA, have been suggested to be effective for patients with osteoarthritis because of their efficacy for attenuating the systemic inflammation response, to dull that inflammation, and the catabolic environment that accelerates cartilage degradation. That's the quote. So it's kind of complicated as the quote, but it's basically saying that EPA and DHA have been suggested for these things. So their finding, pooled results showed that omega-3 supplementation could significantly relieve arthritis pain as compared to placebo. No severe adverse reactions related to treatment of omega-3s were reported among the included studies. Conclusion: compared to placebo or no additional treatment, supplementation of omega-3s can significantly relieve arthritis pain and improve joint function in patients with osteoarthritis. No severe treatment-related adverse events were reported. These results suggest that supplementation is effective and safe in patients with OA. We found that omega-3 is effective in relieving pain and improving joint function in patients with osteoarthritis. Supplementation of the omega-3 fatty acids is effective to relieve pain and improve joint function. Um, so the mechanisms underlying the benefits of the omega-3 fatty acids include, and this is a quote from the article, EPA and DHA supplementation could reduce the expression of multiple inflammatory markers involved in the pathogenesis of cartilage degeneration, such as interleukin-1 beta and inducible nitric oxide synthase. Supplementation of EPA and DHA could reduce interleukin-1 beta-induced activation of nuclear factor kappa B, thereby attenuating leptin-induced cartilage degeneration. Now that gets complicated, I understand that, but the point of it is, it's like the mechanisms that underlie the problems of inflammation can get attenuated or dampened by taking your fish oil. EPA reduces oxidative stress-induced apoptosis. That's what we talked about on Thursday, I think, with what goes on with cancer inside the body, um, and matrix loss of chondrocytes by inhibiting metalloproteinases. That's a big long word, and chondrocyte apoptosis. The optimal dose, components of EPA to DHA, and treatment during the omega-3 supplementation for OA remain to be determined. Yes, that's a very good point right there. It's a very good point because what happens most of the time, in my experience, is that we don't get high enough doses. We get the minimum amount of doses. And I had this conversation with two different ladies today. One of the ladies is a nurse, and I said to her, "Have you been taking your vitamin D?" And she's like, "Yes, I just checked that, and it's high." And she said, "I think it's 50 something." And that's exactly what I would expect someone who's in the medical field to say, because the range just has to be above 30 in order for it to be normal. 30 or 40, I think it's 30. But um, when they're testing the range, they consider you to be within normal range if you're above 30. But they don't get it. They don't get it because the normal range is just enough to not be in some sort of pathology. Do we understand that concept? I hope everybody understands that concept. Let me put it to you in a different way. Do you think that I should tell Leslie that she looks cute in that outfit, or that her hair looks beautiful today, or I love her eyes today, or her eyes should be matched that outfit, or something? I like your shoes. Do you think I should say that to her, like, only when I'm expecting something in return? Do you think that that is only when I want her to um, make supper tonight, or only when I want her to go run errands for me, or something like that? It's like I'm just going to give her the minimum amount of compliments that I can get by with, just to keep her from being mad at me. Like that's all. That's it. Now, all you guys are swabbing their off husbands, you know, dang well, that's a stupid idea, right? You said, why would you do that? Do you know that I told that girl that she's cute almost every single day for the last 30 years? We're no, 36 years. I bet you I have missed very many days where I made some sort of compliment like, "Hey, you look cute today. I like your little outfit. I like your hair. Man, your eyes look pretty today." Like, like I think I told her about 4 or 5 times today that. What am I trying to do? Am I trying to keep myself at a minimum level just to keep her from getting mad at me? Or am I trying to build the most awesome relationship ever seen in the history of mankind between a man and a woman? I'd way rather do that, right? And that's the volume control of our supplements. That's a volume of control. So I had a conversation with one of my ladies, and we were talking about her vitamin D, and she said it was high. It was in the 50s. And I had another lady that checked her vitamin D, and I'm pretty sure she told me it was in the 80s. And I was like, there you go. Like two different two different philosophical things that people say. Two different philosophical belief systems. One person comes to a medical model and says, if I'm just over the threshold of sickness, then I'm well. And the other person is well and rocking out over here. And so we were actually checking her triglycerides and her LDLs because she's a new patient in the office. Today was her second visit. And so she said, where, I said, where are your triglycerides? And she had to look them up on her phone. And she told me something. They were like, I don't know, 60. I told her mine was 36 last time, and she's like, "How do you remember that?" And I said, "Well, I talk about it all the time." And then she said to me, well, "Let me look them up." And so they weren't as low as 36, but they were somewhere in that 50, 60 range or something. I don't remember exactly what the number was that she told me. And then I said, "Okay, you've told me that. Now I bet your HDLs are in the 50, 60 range." And then she looked it up. HDLs are 79. And I said, "Well, then I don't have to care anything about what your LDLs are because I know that your LDLs, according to Dr. Robert Lustig, MD, I know that if you want to know about it, you can go to the rockhealthywellness.com, go to video, and watch the video from Dr. Lustig, and he'll break it down for you, and he'll explain to you when you have low triglycerides and high HDLs, you don't have to worry about your LDLs." And then I asked her, "What's your vitamin D?" And that's what she told me. I think she said in the 80s. And if you want to look at her right eye score is 96. It's almost perfect. Her frontal lobe score is in the 70s, which that almost never happens. Her fixation score was in the 90s. Her pursuit score was in the 90s. So she's almost got a perfect score. Her reflex, pupillary light reflex, had basically no findings. That it was like completely within normal limits. And so her grip strength test was markedly beyond what minimum should be. And she didn't think she'd done anything on her grip strength test. She was like, I don't even. She's like, "Well, how about that thing where I did the?" I said it was great. I said your grip strength test was great. And she said that thing that I squeezed that deal, and I was like, yeah. And she's like, "Why did you feel like I was squeezing it?" I said, "Yeah, but the minimum score was like a 28. She scored a 33, I think. And then on her left hand, it's like a 25, and she scored a 31 or 32 on that one. So all neurological signs were great. She's going to go play golf on Thursday. She just has some structural issues that we got to work on, but all neurological signs were great, and her blood work was great. Right? Those things fit together, and that's. I just want you to know that because that is a um, the dose. This comes back to the article. The optimum dose components of EPA to DHA in treatment during the omega-3 supplementation for OA remains to be determined. Yes, and if you're at question at all whether or not you are taking enough fish oil and you're just taking whatever's on your bottle, double it, go up, see how you do. To sum it up, results of the meta-analysis indicated that supplementation of omega-3 fatty acids is effective to relieve pain and improve joint function in patients with osteoarthritis without increasing the risk of treatment-related adverse events. The findings support the use of omega-3 supplementation as an alternative treatment for osteoarthritis. Am I treating osteoarthritis or trying to treat your osteoarthritis by making this decision or telling you about this story? Absolutely not. I'm not trying to treat your osteoarthritis. That's not something that we do in chiropractic. I don't care anything about your diagnosis. What I'm trying to say is if you get your body in an environment that's congruent with health, you're very likely to inhibit your inflammatory problems that you have. Inflammation inside the body is an indicator that you've got your body in an environment that's incongruent with health, or you've got some sort of virus or something that your immune system's trying to respond to. But that's a valid problem right there. It's a valid statement. It's not a problem. It's a valid statement. If you get your body in an environment that's congruent with health, your body will express health. That's what your cells are made to do. So sometimes you got to increase your fish oils, and that came right straight from Journal of Orthopedic Surgery and Research. Okay, so that's omega 3. Here's one on gabapentin, right quick. We'll get these next two. I'll try to get them. I might try to get this one maybe, and then I want to talk about Diet Cokes here for the second half of the show. But this is from the British Medical Journal, and it's open. I don't know what version of open that is. So, um, associations between chiropractic spinal manipulation and gabapentin prescriptions in adults with radicular low back pain. Retrospective cohort study using U.S. data. So, this is one of those moments, right? This is one of those moments that my dad would he bought into that whole model when he was 20 years old, and he didn't have an option. He didn't mean to. It was I'm not talking trash about my dad. I'm saying that he didn't know any better, and so he just did what they told him to do. And aspirin turned into um, Tylenol and Advil, which turned into gabapentin, which turned into OxyContin, which turned into morphine. That was his model. That model that he followed was like this. I took him fish oil one time, and I said, "Dad, this is exactly how you got to take it because if you don't, it'll ruin because you need volume." So I gave it to him at Christmas. Called him in February. I said, "How you doing?" He said, "Man, this is working pretty good. Like, I actually like. I think this fish oil is helping." I called him in April. I said, "How you doing? Need some more fish oil?" And he's like, "Oh, that stuff is nasty. I'm not taking that stuff anymore. That stuff is, boy, it is nasty." Dad, okay, hang on now. Um, why is it nasty? I said, "Did you do what I told you to do? Did you open the lid, pour it in the spoon, take it, put the lid on it, put it back in the refrigerator?" No, well, I might have left it on the counter. I might have left it on the counter for a bit. Mhm. You can't leave fish oil out on the cabinet. You can't leave fish out on the cabinet. You can't just leave your fish out. If you cook fish and you just left it out on the cabinet, what would happen to it? It would spoil, right? It's fish. That's the same thing that happened to the fish oil. And so my point is, I just went over osteoarthritis and fish oil. Now let's talk about chiropractic care, gabapentin. So this study was done by a group of guys. The study cites 79 references. The study was the first to examine the association between chiropractic spinal manipulation therapy and the likelihood of gabapentin prescription among patients with ridiculous low back pain. Participants were adults aged 18 to 49 who were having their first episode of radicular low back pain diagnosis, meaning their age was 36 years and 60% were women. Oh, their mean age. Their mean age, their average age was 36 years and 60% were women. Only patients with this low back pain were included in the study, and this type of low back pain often involves neuropathic pain. Okay? And we got an article review on that too. Neuropathic pain means that there's nerve in this whole thing that's causing this deal. Exclusions, um, they worked through all that stuff. There were 77 healthcare organizations. There were 1,635 patients in the adjustment cohort, and there were 1,635 patients in the gabapentin cohort. Authors hypothesized that adults under 50 years of age receiving adjustments for newly diagnosed low back pain would have reduced odds of receiving gabapentin prescription over a 1 year follow-up. Usual medical care was defined as a range of medical services besides chiropractic care, including physical therapy, medications, and interventions or surgical procedures. And then some of the key points from the article. Here we go again. The U.S. has the leading age standardized prevalence of low back pain in the world. If we're leading the world in low back pain, we should maybe someone would care about that. Together, low back and neck pain account for the leading cause of medical expenditures in the United States. That means spending money on things. That means paying the money out of your own pocket for the pain. It's the it's the leading cause of medical expenditures in the United States. Ridiculous low back pain is often treated off-label with gabapentin or by chiropractors using chiropractic spinal manipulative therapy. So it's or. Because you go to your doctor, what's your doctor going to do? Is how many times is your doctor going to send you to your chiropractor? He's like, hey, nope, I don't want you to take any of this stuff. Because let me tell you what happens. If you start taking this gabapentin, pretty soon you're going to be taking oxycontin, and pretty soon you're going to be taking morphine, and then pretty soon you're going to die. I don't want you to do that. I want you to get this thing solved, get your body back functioning properly. I need to send you to the chiropractic office. How about all of the nurse practitioners out there? I didn't make this up now. This is coming from the British Medical Journal. So it's like, and those people are not all fabulous in my world. I'm just saying. But so let's think about this. It's either well, the chiropractors are quacks. The chiropractors are going to hurt you. The chiropractors don't know what they're doing. Blah 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 blah. Right? We hear that stuff a lot. Radicular low back pain, which involves a nerve root lesion, is considered a type of neuropathic pain and involves radiating symptoms into the ipsilateral lower extremity, the same side. So you got pressure somewhere in your low back, putting pressure on a nerve. You're getting pain running down your leg. That's what they're talking about with this type of stuff. Um, Gabapentin is an anticonvulsant, anti-epileptic medication used as first-line therapy for several types. Hang on, hang on. Whew, I missed the cutoff. Sorry, I just been talking right through the. Hang on, I messed that up. Give me a second. Um, I had my volume turned down too low, and I just went right through the commercials. So I better wait just a second and get the get get us back to the commercials. So sorry about that, Ken and Bob, on my radio guys, and all of our advertisers. So I apologize for that. If you guys have any comments or questions, you want to send them to us. Send them this way. We'll get them answered. I'll try to get all that stuff answered for you. Um, I've noticed that there's been some Twitter people following us. You guys, welcome to the show. I don't know, I'm getting some weird stuff, but all you guys from the Twitterverse, um, X, that are checking us out on X, welcome to the show. If there's questions that you have, you can text me anytime, 806-794-0400, and I'd be glad to answer any of your texts. You can text me live during the show, and a lot of times I'll get them, or you can text me anytime after it on the show. And I don't know if I miss any comments otherwise that are left on X. I'm not exactly sure if I missed any of that stuff, but okay, we're back. This is live, Jason Clemmons, DC, and I really apologize. I missed that break. I had my volume turned down too low, and I walked right through the middle of that. So I apologize for that. For you guys, I apologize to advertisers, and um, I'm sorry about that for anybody who's listening. So, but we're talking about gabapentin. And I want to just finish this up, and then we'll get into the diet drink stuff. Gabapentin is an anticonvulsant, anti-epileptic medication used as first-line therapy for several types of neuropathic pain, including diabetic neuropathy and herpetic neuralgia. Gabapentin may alleviate neuropathic pain by binding to a subunit of voltage gate calcium channels, subsequently inhibiting ectopic nerve discharge. Yeah, you're jacking with the function of the way that the nerve fires. Gabapentin has been used off-label to treat neuropathic symptoms for low back pain, namely radicular low back pain. It's always funny. The gabapentin has had U.S. Food and Drug Administration approval for use in neuropathic pain conditions since 1993. Systemic reviews in 2018 and 2022 demonstrated clear evidence of lack of its effectiveness for low back pain. There's growing evidence of risk association with gabapentin use, including abuse, misuse, dependence, and withdrawal. Other deterrent effects of gabapentin include excessive sleepiness, dizziness, ataxia, fatigue, and new onset weakness or lack of energy symptoms. Several clinical practice guidelines do not recommend gabapentin for the treatment of low back pain or radicular low back pain, including those of the American Family of Physicians. Now, I'm not reading this. This is coming straight from the British Medical Journal Open. Gabapentin prescription for low back pain has been described as a marker of low value care and medical overuse. Despite um, paucity of evidence and in contrast to clinical guideline recommendations, gabapentin continues to be commonly prescribed for low back pain. This is a super important sentence that everybody can understand. Chiropractic portal of entry providers in the United States who frequently treat spinal disorders. That's a huge thing. If you don't know that, a portal of entry provider is a provider that can see anybody at any time for anything, any new patient. You do not have to have a referral to come see a chiropractor. Now, if you have an HMO of your insurance, the HMO tries to be the gatekeeper, and they try to use the medical doctor as the gatekeeper to come in. But you would have to have it in that particular case. But if you didn't want to use your insurance, then you can come straight to your chiropractor's office. We are portal of entry doctors. We do not need a referral for you to come see us. Now, if you have something that's outside of our scope of practice, then we need to make sure that we get you to the right doctors for that. Um, I'm just going to speed this up right here. The chiropractic spinal manipulative therapy is a hands-on treatment directed to the joints of the spine. So, studies have found that the initial type of provider seen for low back pain influences the subsequent likelihood of receiving a prescription for certain medications. If you go to your medical doctor first, you're more likely to get a prescription. If you go to your chiropractor first, you're more likely not to get a prescription. Patients initiating care for low back pain with chiropractors compared with other providers have reduced odds of receiving an opioid or benzodiazepine prescription. And the findings: gabapentin prescription was less frequent in the adjustment cohort over 1 year follow-up and after radicular low back pain. After matching, odds of gabapentin prescription over the 1 year follow-up were significantly lower in the adjustment group than with the other group receiving usual medical care by 47%. The real world findings of our support our hypothesis that adults initially receiving adjustments for low back pain have reduced odds of ever receiving gabapentin prescription over a year of follow-up. Our findings are similar to those of previous studies which demonstrated an association between initial receipt of adjustment and reduced odds of prescription opioids, benzodiazepines. Our findings add to growing evidence that the receipt of an adjustment early in care pathway for new onset of low back pain could lead to a greater accordance with these guidelines with respect to medication prescription practices. Uh, yeah, that's we know that. We know that. You might not know that. If you want to stay off drugs, then you better off if you're getting adjusted. So that's the two of them right there. So let's talk about we're gonna save there's another one that I'll save it for tomorrow. It's the same thing, chiropractic and benzodiazepines. But I want to get into this conversation about Diet Coke because there's a there's a belief system that well, and I used to be one of these people that believe this actually uh, that if you drink diet drinks, then it's healthier for you than if you don't drink diet drinks, and it's absolutely not. Let me see. I got Let me find my article because I had them all open and there. Okay, so let's talk about them. And I've got three articles I don't want to talk about, and we'll talk about some of the things that you may or may not know about diet drinks. Uh, and let me get these. There's one, and let's just talk about feeling the obesity epidemic. We'll just talk about it right here. Artificially sweetened beverages used in long-term weight gain, obesity. This came from the Journal of Obesity, August 2008, volume 16, number 8, pages 1894 to 1900. And this was done by the Department of Medicine, Division of Clinical Epidemiology, the University of Texas Health Science Center in San Antonio. From abstract, we have examined the relationship between artificial sweetened beverages consumption and long-term weight gain in the San Antonio Heart Study. From 1979 to 1998 to 1988, height, weight, and artificially sweetened beverage consumption were measured among 5,158 adult residents of San Antonio, Texas. 7 to 8 years later, 3,682 participants were re-examined. Outcome measures were induced of overweight, obesity, incidence. Can't read sometimes. Outcome measures were incidence of overweight, obesity. A significant positive dose response relationship emerged between baseline artificially sweetened beverage consumptions and all outcome measures. Consuming more than 21 artificially sweetened drinks per week versus none was associated with almost double risk of obesity and overweight, 93% increase in incidence. Among the baseline normal weight individuals, a double risk overweight obesity was noted at follow-up, 103% increase incidence. These findings raise the question whether artificial sweeteners used might be fueling rather than fighting our escalating obesity epidemic. So this is back in 2008, right? So they're really trying to find out does this matter? Does it make any difference? And I want to take us back to our Charles Zucker conversation that we had. If you guys didn't listen to that, you can go back and find it. Find it. I try to put it on Facebook and label it properly so that you can have it. But if you go back and look, it's a really important point that that fantastic study that he did with the mice that I can reference all the time. Um, what he was talking about, and in what is really neat to understand, and Doctor Lessig says the same thing. He talks about the leptin, and he talks about how what we don't do when we drink diet drinks, so we don't shut off the the mechanism that we don't mechanism started that shuts off our hunger. And to talk about it a little bit, well, I'll just show it to you, and you can kinda understand it right here. So, we have sweet receptors on the tongue, in the mouth, okay? We have sweet receptors in the mouth. We all think that the reason we like stuff is because it's sweet. That's what we think. But we also have glucose receptors in the small intestine. Now, why do we have those glucose receptors in the small intestine? Because our innate intelligence wants to know, "Hey, I felt it in the mouth. I thought it was sweet, but did I actually receive it in my small intestine?" Because what are the 3 things that your brain needs? Your brain needs glucose, oxygen, and excitability, okay? Glucose, oxygen, and excitability, that's what the brain needs. It needs those 3 things. Your brain actually likes glucose. It does rather well on glucose, right? how you get glucose, where it comes from, how your body processes it. Those are all the things that you got to look at. So your brain wants to know, hey, did I get it? Now, how's your brain going to know? How's your brain going to know that you've received that in your small intestine? It's going to use the vagus nerve. You're going to use your vagus nerve, which is the nerve. Everybody knows about the vagus nerve now, right? That's like a popular thing these days. So the vagus nerve is one of those things. It's like everybody's starting to really understand. It's 85% sensory, meaning it's 85% from the body into the brain. It's going in that direction. So it's 85% that way. Then it's only 15% coming from the brain back down to the organ system. So what we're getting is lots. I was studying this brain mapping stuff that we're doing in the office now. I was studying that this weekend, and one of the things that the doc taught me this weekend was that if you have beta amyloid in your gut, and I haven't really broken down why you would have that in your gut, but if they did a study and they said that if you have beta amyloid in your gut, that you will end up with beta amyloid in your brain, and that beta amyloid has a lot to do with Alzheimer's disease, right? So if you've got it in your gut, it'll end up in your brain. If you've got it in your brain, it will also end up in your gut, and it's traveling through the fibers of the vagus nerve. And the vagus nerve is not just one single string going from your brain down to your organ system. You're it's a bundle of strings that are going there to the different areas of your intestines, to all your organ systems, all the way down, right? To like the last one third of your colon or something. It's it's going all the way through your system. And so there's these pieces of information that are constantly traveling between your small intestine and your brain. So what does that have to do with diet drinks? Well, what happens is we get the diet drink, we get the check mark of the we get the sweet receptor in the tongue, on the tongue or in the mouth. And there's a couple of places that Dr. Zucker explained in the mouth. That's why instead of just tongue. But there's a couple of places there that we get those sweet receptors. So now, but we're getting a sweet receptor that's just tasting sweet. It's not tasting glucose. It's just tasting sweet. So anything that we use to trick it, when we ingest it, is going to end up it's going to end up going through our small intestine, but going to it's not going to use that glucose receptor that's in the intestine to feed back to the brain. And if it doesn't do that, then it's not going to tell your brain that you're full. It's not going to tell your brain that you're happy. It's not going to tell your brain that, oh, I now I got what I needed. It's gonna tell your tongue that you got what you needed, and your brain's gonna be sitting there waiting on that next piece of information. And there's all kinds of studies that say people that drink diet drinks eat more. And that's kind of what's going on here with the caloric intake. They eat more. They go to the McDonald's and they'll get a McDonald's and a French fries and a Diet Coke. And why are they doing that? It's like, what will the Diet Coke do for them? The Diet Coke will tell them that they're not full. They're not getting that information through the vagus nerve and from the small intestine back up. It's just one component of the mechanisms of diet drinks. But that's what this article is trying to say to us. And this article's been around for quite some time, since 2008. It's exactly what this article is saying, is that if you have a consumption, it was associated with almost double risk of obesity, 93% increase. So over 6,000 products include food, beverages, cosmetics, and pharmaceuticals contain aspartame alone. These authors assessed long-term weight changes among participants in the San Antonio Heart Study who used artificial sweetener products compared with those who did not. During the past 30 years, people have increasingly turned to artificial sweeteners and beverages in an attempt to lose weight or control it. So here's an article saying that doesn't work. Sugar sweetened beverage consumption was 75% less in the artificial sweeteners beverage users compared to non-users. So if you didn't use aspartame or whatever, obviously the sugar sweetened ones were up. Percent of calories from protein, total fat, and saturated fat was significantly higher in artificial sweetener users. Suggest appetite control damage. Or that's what Dr. Murphy's note was. Suggest suggesting appetite control damage could be, but it also could be this thing Dr. Zucker's talking about is that we don't have that shutoff, and that's Dr. Lustig is kind of saying that same thing. But so it's a huge piece of information right there, right? Um, Let me go back just to make sure. This is from the Journal of Obesity. If you're drinking Diet Cokes, the percent of calories from protein, total fat, and saturated fat were significantly higher. You're eating more food, usually, because you're drinking the Diet Coke, because you're not getting the appetite suppression that you need from there. Diet Dieting rates about the same in both groups. The researchers adjusted um, the original research for baseline of several things. Overall, obesity showed significantly dose response relationship with artificial sweeteners consumption. For each artificial sweetener beverage consumed, users experienced significantly higher increase in body fat and body mass index. Several studies have described increased appetite, hunger, and food consumption following this artificial sweetener exposure. Other studies show that the incidence of metabolic syndrome increases with increased diet soda consumption by 34 to 53%. Increased incidence of metabolic syndrome has been observed among artificial sweetener users in two major observational studies. The authors suggest that because artificial sweeteners are 180 to 13,000 times sweeter than sugar, their consumption leads to taste distortion, increasing appetite for intensely sweet, high caloric foods. Artificial sweetener use or sweet taste itself may increase hunger, cravings, or food intake. So that's a big deal, I think. I think it's a big deal to understand that if you're hooked on Diet Coke, you're setting yourself up in multiple levels. We've just talked about the gut glucose receptor. We talked about the increase in fats and proteins. Just the increase in calories, period, is increased. And now we're talking about a possibility of taste distortion because there's not that much there's not that much sweetness when you start to break yourself off of it. So when we were talking about our this weekend in my Brain Master training, um, the doc that was helping me from New Jersey, he said that he had a person that um, was really smoking marijuana a lot, and her and her husband both they were all into that whole marijuana thing, and I'll just let me say something real quick, just for the people in Lubbock who are listening to this show, just to the people in Lubbock who are fixing to vote on whether or not we should make marijuana legal. You know, the way I feel about it, the way I really feel about it is that I'm not a big, um, I'm not a big me tell you how you're supposed to live guy. I'm I'm more I'm more of a hey, it's it's a free country. You can do what you want type of deal with it. Okay. I also am a bigger believer in a republic than a democracy, and I think in a republic you ought to have responsible people making decisions for the group that are elected officials. We got to have checks and balances. But I don't think it's a great idea to open this up to the public because I know what the public's going to do. They're going to do whatever they want based on their decreased brain function and left brain jacked upness and all that stuff, right? So we're fixing to vote on that in Lubbock. All I can tell you is this: your brain maps are altered for up to 3 days after you smoke one joint. When we try to do brain mapping on you, when we do brain mapping on you, up to 3 days after smoking one joint, your brain maps are altered. So just If you want to know how your body functions on weed, it doesn't. Increased anxiety happens because what happens is we that up and to the right, over to the left pathway that I'm always talking about gets stuck in the right. So we get hyperactivity of the right brain and we get lower activity of the left brain. And the hyperactivity of the right brain causes anxiety. And so we'll get an increased amount of anxiety for the increased amount of marijuana smoked. So I just want you to know that part of it. But he was talking about what my doc was talking about was one of his ladies that he started treating with the neurofeedback. She just one day came in and said, "I just don't feel like I need to smoke weed anymore. I still like weed. I just don't feel like I need it." And man, that resonated with me a lot because I totally understand what he's talking about. Like the um, the the need for sugar got broken, and we had a kind of had an aside moment where we had a discussion about what was going on right there. And what I told him was that I had that same experience. And what I think happened is that once once you got the brain to fire in the proper manner, and once you got the dopamine set properly in the left hemisphere, once you got that balance to happen, you lost your desire for that weed. The reason that people want to smoke weed is because their left hemispheres are hypoactive. That's my belief system, 100%. That's the same reason they wanna eat sugar. That's what bothers me about this vote that we got coming up, because nobody's gonna vote for decreasing sugar, and nobody's gonna vote for decreasing sodas, and no one's gonna the diet sodas aren't on the vote. We're not voting to take away diet sodas in our land. We're not voting on taking away gabapentin for those people that haven't been adjusted. We're not taking away that. See what I mean? It's like we're just gonna pick and choose what it is we're gonna vote for. I'm gonna vote no. Of course, I don't want people on it, but it's not good for your brain. It's not good for your health. But neither is sugar, and neither is diet drinks. But the point of it is, she balanced it out by getting her brain balanced out, and there's evidence of this in this article right here that we might have some problems with that. So I'm gonna get down this. It's a lot, but basically you got that right there, right? Um, Several studies have described an increased appetite, hunger, and food consumption following artificial sweeteners. Other studies show that incidence of metabolic syndrome. I read that one. Authors suggest that because artificial sweeteners are 180 to 13 times sweeter than sugar, it leads to taste distortion. You got that. Studies have shown that AS causes elevated insulin levels. Yeah, because you your body's not processing it's the other foods that you're eating. Aspartame is 40% aspartate. Aspartate is toxic to neurons in the um, arcuate nucleus of the hypothalamus. The arcuate nucleus of the hypothalamus is a key site for leptin signaling. There's that whole thing with Dr. Lustig. Leptin signaling in the arcuate nucleus of the hypothalamus instructs us to reduce food intake. The earlier the exposure to excess aspartate, the more profound the damage to the arcuate nucleus. So, the earlier you start getting aspartame, the more you start having problems with your diet drink, the more that you start to develop this leptin signaling problem, and that can cause problems for us. So, that was quick, but I hope you guys enjoyed it. I've run out of time, and I'm not gonna break down twice in the same show and mess up the end of the show. So basically, our take home for the night is this: artificial sweeteners are bad for you. If you drink a Diet Coke, you'd be better off if you drank water. So that's what I got. Hope you guys have a great night. We'll see you tomorrow night at 6.